Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been teaching in Bangalore for the past 2.5 years. Today's topic is MCQ on patient positioning in anesthesia. I took this topic in 2 parts, and today we'll be doing a quiz on it with the questions. So, a little about Unacademy. This is one of India's largest online learning platform, where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. Now, what will you get out of Unacademy? So we have our daily live classes where you can chat with your educator, engage in discussion, ask your doubts and answer both, and all while the class is going on. So basically, what I mean is, now when you have coaching classes, excuse me guys, just a sec, I'll be back. Sorry. So basically, we have our daily life classes. So basically, uh, when your educator over there in a live class in a coaching institute, it's very difficult for your educator to clear everyone's doubts, because everyone is like, basically, it's his or her flow of thought breaks in that stipulated amount of time. They have to finish everything, so it's very difficult for them to clear everyone's doubts. Whereas at Unacademy, while the class is going on, we will clear your doubts regarding the subject. These are structured courses, so all our courses are structured and are in line with your syllabus and helps you best to prepare for it. So the educators have researched, and whatever is required from syllabus point of view is prepared for you. Live tests and quizzes. So we evaluate your preparation. We have our regular live tests, quizzes, and all that, and which will help you evaluate your, like today. After completing the topic, I'm conducting a quiz, and then we have a grand quiz at a later date. Um, so this will help you evaluate your preparation on a regular basis. So now there is unlimited access. So one subscription gets you access to all our live and recorded courses, and you can watch from the comfort of any device. So basically, from whichever device you're using, whether it's your phone, your laptop, wherever your app is, or YouTube, you all can watch from the comfort of your home. These are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Preeti Sharma. Dr. Nikita Nanwani is a NEET PG mentor for radiology, as well as mnemonics and concept focusing. Mnemonics is a very interesting part. If it works well for you all, it's very good, as it helps you all study better. For me, mnemonics never really worked, but also if not, I would suggest. Otherwise, I would always suggest, if mnemonics works well for you all, please use your own mnemonics. It's really helpful. It will really help you all. These are some of the courses offered. So as you can see on the screen, there are various courses. There are various subjects that you all have to cover. It's a lot. I know NEET PG is not easy. There is so much to cover. It's 4.5 years of undergraduation plus extra subjects which you really didn't have in detail in your undergraduation. You all have to cover. So there is a lot to cover, I know. And it's not easy also. So like I said, we are here to help you all. And topics like dermatology, psychiatry, radiology, anesthesia, they're all allotted 11 marks for each for the NEET PG. Now, we never really had to go into detail during undergraduation, right? During MBBS, we didn't have to go into detail into the subjects. It was very superficial kind of thing. But over here, we need to know, so it's not going to be, unless you know something about the subject a little in depth, it's going to be very difficult to give to answer the question. So you need to know a little about the subject. So for that, that is why we have prepared, that is why, so we conduct these classes, so we, for these subjects. Now it is very easy to score those 11 marks, because like during your undergrad you already have to go into that much of depth. Even over here it is more of the basic stuff, common stuff that will be asked to you all most of the time. So these subjects are scoring, you must not miss out on those 11 marks. Whereas your physiology, microbiology, biology, all these subjects actually have been avoided 44 marks each, and they can ask you anything from anywhere because you spent a year during undergraduation studying it. These are some of the ongoing courses on our platform: course on neurophysiology, GI surgery, cardiovascular thoracic surgery, larynx, respiratory system pathology. Now coming to the subscription part of it, as you can see on your screen, there are 5 types of subscription. Those of you who want to clear this year, want to clear the exam this year, so your 6-month subscription is more than enough. Sorry. And 12 and 24 month is what I would highly recommend you all go for if you all are planning for the long term thing. No one is going to ask you how long you took to clear NEET PG, how many years you spent. At the end of the day, it's all practice, and it's how you perform in your at your job. Nobody is going to ask you how long you took. Nobody cares about it once you're a consultant. So also it's more economical. So it's a one-time subscription. So after 6 months, if you want to access the, access anything like the what do you call it, the classes or the tests and all, you can't. You'll have to pay again, which is not economical, right? But with the 12 and 24, you have the buffer, right? So you have the buffer of that. Then, of course, like I said, those subjects which we didn't have to study much in detail, so we don't know much about the subjects, right? Because we haven't studied much in detail. So when you're studying, you might actually, it's not only about those subjects. Even when you're studying, you might realize, oh, you don't like, maybe you don't like medicine, you want to take up ophthalmology, or you don't like ophthalmology, you want to take up anesthesia. So that it helped me. That's how I realized what I wanted, because I realized what I didn't want. So it does help you exclude things, right? Because you're doing this for the rest of your life. You need to love what you're doing. You need to enjoy what you're doing. Otherwise, there is no point, really, quite frankly. Use my code SASHA to avail this a 10% discount. So if you use my code, you get a 10% discount. So this is for the 12-month subscription, and this is your 10% discount. Now, same thing applies for the 24-month subscription. Use my code and avail a 10% discount. Okay, now let's move on with class. So I'll be keeping a timer. I'll be setting a timer. Just setting the timer, and then we'll move on to the first question. Okay, guys? Okay, timer will be for 1 minute per question. Timer will be for 1 minute per question. Okay, done. Your time starts now. Normally, as an individual reclines from an erect to a supine position, the following changes occur. There's an increase in preload, an increase in cardiac output, decrease in stroke volume, increase in preload, cardiac output, stroke volume, decrease in preload, cardiac output, stroke volume, increase in preload and stroke volume, and decrease in cardiac output. So your answer is an increase in preload, cardiac output, and stroke volume. So basically, when a patient is standing and then he reclines, so there will be, in the standing position, there will be pooled blood. Blood will be pooled. So in the reclining position, there will be blood returning to the right atrium. So there will be increase in your preload, cardiac output, stroke volume, and all these will lead to an increase in blood pressure. This is in a normal patient. Next question. Systemic arterial blood pressure is maintained within a narrow range during postural changes in the unanesthetized setting by which of the following? This is not there. Sorry. By which of the following? So this is a compensatory mechanism for the increase in blood pressure that we discussed about in the previous question. So it is, how is this compensatory mechanism brought about, by which of the below? So your answer is all of the above. So basically your afferent baroreceptors, that is your carotid baroreceptors located in the carotid and aortic, excuse me. So baroreceptors located in the carotid and aortic arch, they sense an increased BP because of the increased preload, cardiac output when the patient, when the postural change occurs from the supine to from the erect to supine position, and they decrease these, once they sensitize the increased BP, they decrease the sympathetic activity and they increase the parasympathetic activity. Okay? So, which brings about a decrease in BP. Other factors which play a role are the mechanoreceptors in the atria and ventricle, the stretch receptors, they also decrease the sympathetic outflow, and atrial reflexes. So any renal sympathetic activity, nerve activity that is occurring because of this increase in BP is activates the atrial reflexes, which decrease it. So all these play a role in maintaining the blood pressure. So during positive pressure ventilation, a positive pressure ventilation brings about which of the following changes? So does it bring about increase in mean intrathoracic pressure, increase in venous return, decrease in cardiac output, increase in mean intrathoracic pressure, venous return, cardiac output, and decrease in mean intrathoracic pressure, venous return, cardiac output, increase in mean intrathoracic pressure, decrease in venous return and cardiac output. So the answer is an increase. So whenever there is positive pressure ventilation, PEEP, positive pressure ventilation or positive end expiratory pressure, or any conditions which decrease compliance of the lung. So compliance of lung is decreased, or PEEP or positive end expiratory positive pressure ventilation when present. It increases the mean intrathoracic pressure. When this mean intrathoracic pressure increases, it causes a decrease in venous return, decrease in cardiac output, and a decrease in BP. So positive end expiratory pressure increases mean intrathoracic pressure further as conditions such as which of the following which condition below brings about the same effect as positive end expiratory pressure. Your answer is all of the above. So these are the conditions which cause a decrease in lung compliance. If a light plane of anesthesia, any airway disease like bronchiolitis, obesity, COPD all cause an increase in positive and increase in PEEP, and hence increase the intrathoracic pressure, which leads to a decrease in venous return and decrease in cardiac output, leading to a decrease in BP. So basically with anesthesia, when a patient goes from the erect to supine position, the compensatory mechanisms that we discussed, the baroreceptor reflex and all are lost. So there is no compensation occurring. So basically those compensatory mechanisms maintain the, so in the erect, basically there is a distance between the heart and the brain, right? So the perfusion to the brain has to be maintained. We are erect beings. We are not on four legs. So our heart and brain is at a different level. So perfusion has to be constantly maintained for good blood supply to the brain. So to do that, hydrostatic the pressure has to be maintained. So because of that, when the patient, those compensating mechanisms come into play in a normally unanesthetized individual, but when the individual is anesthetized, these compensatory mechanisms are lost. So when these compensatory mechanisms are lost, it becomes a problem, right? In these anesthetized patients, so when these compensatory mechanisms are lost, basically you should maintain the perfusion has to be well maintained, the BP has to be maintained. So when an individual shifts from standing to supine, the following respiratory changes occur. So which respiratory change occurs when an individual shifts from the standing to the supine position? answer is 3. So when an individual shifts from standing to supine position, there will be a decrease in functional FRC, a decrease in tidal volume. So basically the organs all push the diaphragm up, which causes an increase in intrathoracic pressure, decrease in venous return. Also, it causes a decrease in FRC, decrease in tidal volume, and increase in the closing volume. So hemodynamic reserve is best maintained by which position? Lateral decubitus, dorsal decubitus, ventral decubitus, or lithotomy? Is best maintained by both these positions, the dorsal and ventral. So this is basically a supine. Since the heart and the brain at the same level, the hemodynamic reserve is maintained by both, but preferably by the dorsal. All the following are true except the entire body is close to the level of the heart. Hemodynamic reserve is best maintained. Because compensatory mechanisms are blunted by anesthesia, even a few degrees of head down or position or head up position are sufficient to cause significant cardiovascular changes. In a supine patient, one or both arms may be abducted to the side or adducted alongside the body. It is recommended that extreme upper abduction be limited to less than 120 degrees. All the following are true except So it is recommended that upper extremity abduction be limited to less than 90 degrees. This is to avoid strain on the brachial plexus. The entire body is close to the level of the heart, and hence the hemodynamic reserve is best maintained. Yes, the compensatory mechanisms are blunted with anesthesia, so any change in position can cause significant cardiovascular changes. And in a supine patient, the arms can either be abducted or tucked by the side. All the following are false except tilting a supine patient head down. The reverse Trendelenburg position is often used to increase venous return during hypotension. Trendelenburg position and reverse Trendelenburg position, shoulder bases should be used to secure patient. The head down position decreases central venous, intracranial and intraocular pressure. Prolonged head down position can lead to swelling of the face, conjunctiva, larynx and tongue with an increased potential for post-op upper airway obstruction, which of all are false except The answer is 4. The prolonged head down position can lead to swelling of the face because of increased venous return. Hence, there will be swelling of the conjunctiva, larynx, and tongue. So, there is increased potential for upper airway obstruction. That's why a heat test must be done prior to extubation after prolonged ventilation in the head down position. So, basically, a stethoscope is kept over the larynx and pushing sound is looked for. So basically, if there is no edema, when the cuff of the tube is deflated, the air will pass on either side of the deflated cuff between in the vocal cords, and you will hear a whooshing sound when the patient is breathing. But with airway edema, the edematous mucosa will be kissing the tube even if the cuff is deflated, and no air will escape, and there will be no whooshing sound. So in such a case, the tube is maintaining the patency of the airway. If the tube is removed, there can be airway obstruction because the two mucosal surfaces can touch each other. Now, tilting a patient head down is the Trendelenburg position, and yes, it is often used to increase venous return during hypotension. Trendelenburg and reverse Trendelenburg position, shoulder braces should not be used to secure the patient because they cause injury to the brachial plexus, and the head down position increases intraocular pressure, intracranial pressure, and central venous pressure. All the following are true about the Trendelenburg position except cephalic movement of the abdominal viscera against the diaphragm increases functional residual capacity and pulmonary compliance. In mechanically ventilated patients, airway pressures must be higher to ensure adequate ventilation. The stomach lies above the glottis and endotracheal intubation is often preferred to protect the airway from pulmonary aspiration related to reflux and reduce atelectasis. Because of the risk of edema to trachea and mucosa surrounding the airway during surgeries in which the patients are in Trendelenburg position, it is prudent to verify an air leak around the endotracheal tube or visualize the larynx before extubation. Yes, so your answer is number 1. So the cephalic movement of abdominal viscera in the head low position that is your Trendelenburg position. So the cephalic movement of the abdominal viscera against the diaphragm actually decreases the functional residue. We just discussed this, so I hope you all got this right. Okay, so mechanically ventilated patients, airway pressures must be higher to ensure adequate ventilation. Yeah, stomach in Trendelenburg position, the stomach lies above the glottis and it's higher risk for aspiration. Hence, endotracheal intubation is preferred to protect airway from this, to protect the airway from pulmonary aspiration risk. And this is the previous point that we discussed about the airway edema. Reverse Trendelenburg, all are true except so the answer is Is venous return. So basically, reverse Trendelenburg is a head up tilt. So there will be a decrease in venous return because of pulling blood in lower extreme. So then the reverse Trendelenburg is often employed to facilitate upper abdominal surgery by shifting the abdominal contents caudally towards the foot end. This position is increasingly popular because of the growing number of laparoscopic surgeries, yes. And the position of the head above the heart decreases the perfusion, and hence whenever there is BP fluctuation, this has to be kept in mind because perfusion to vital organs has to be maintained at all times. The following are complications associated with the supine position except. The answer is the most common peripheral injury with the supine position. Yeah. And so pressure, alopecia, yes. Backache, yes. Tissue or overlying all bony prominences must be padded, otherwise it will lead to ischemia in these areas of necrosis. So all are true about the lithotomy position except so is true. 2. Both legs should be raised at a time, basically together, flexing the hips and the knee. So the lower extremity should be padded to prevent compression against the stirrups. The classic lithotomy position is frequently used during gynecological, rectal and urological surgeries. Yes, an initiation of the lithotomy. So coordinated position, two assistants have to hold either of the one leg each, and together they have to raise the leg and then by flexing the hip and the knee and then making the patient supine or putting the patient in the lithotomy position. This is to avoid torsion on the back and prevent lumbar dislocation. The following are true about the lithotomy position except Hips are flexed at 80 to 100 degrees from the trunk. Legs are abducted at 30 to 45 degrees from the neck. Lower extremity padded to prevent compression against the stirrups. The normal lordotic curvature of the lumbar spine is well maintained in the lithotomy position. So the answer, I'm sorry. The answer is 4. The normal lordotic curvature of the spine is lost in the lithotomy position. That is why carefully the patient has to be put and taken off from the position by coordinated effort of 2 people lifting the legs at the same time. So the hips in the lithotomy position in the stirrups, the hips are flexed at 80 to 90 from the trunk and the legs are abducted 30 to 45 from the midline. This is the correct lithotomy position and the lower extremity should be padded to prevent any compression against the stirrups. All are complications of the lithotomy position except when the legs are elevated, preload increases, causing a transient increase in cardiac output and to a lesser extent cerebral, venous, and cranial pressure in all the otherwise healthy patients. The lithotomy position maintains lung compliance and tidal volume. Normal lordotic curvature of the lumbar spine is lost in the lithotomy position. Lower extremity compartment syndrome. So the lithotomy position does not maintain normal lung and tidal volume. So in lithotomy position, what happens? The abdominal contents press on the push the diaphragm upwards. This will decrease lung compliance and decrease tidal volume. So legs are elevated. Yes, preload will increase, causing a transient increase in cardiac output, which is not significant in healthy patients. Normal lordotic curvature of the lumbar spine is lost in the lithotomy position and can predispose to lower back pain and lower extremity compartment syndrome can develop. The most common lower limb neuropathy is Your answer is common peroneal nerve. It is the most common lower limb neuropathy. All are true about lower limb compartment syndrome except local arterial pressure decreases by 0.78 centimeter. The leg is raised above the right atrium. Irreversible muscle damage occurs with pressure above 15 millimeter of mercury. Decompression fasciotomy is performed if tissue pressures are over 30 millimeter mercury. Deperfusion after ischemic injury offers protection. Your answer is perfusion after ischemic injury is harmful. It's actually harmful. There is no protection. Okay. So the local arterial pressure does rise 0.78 mm every centimeter the leg is raised above the right atrium. Irreversible muscle damage occurs with pressures over 50 mm of mercury, and decompression fasciotomy is performed if tissue pressures are over 30 mm of mercury. All are true about the lateral decubitus position except lateral decubitus position is used most frequently for surgery involving the thorax, retroperitoneal structures or hip. Uh, the patient's head must be kept rotated to prevent excessive lateral rotation of the neck and stretch injury to the plexus. Dependent ear should be checked to avoid folding and undue pressure. Verify that the eyes are securely taped before repositioning if the patient is asleep. So the answer is this: the patient's head must be kept neutral. The patient's head has to be neutral to prevent lateral rotation of the neck and stretch into the brachial plexus. Uh, it is most frequently used for these surgeries, and the dependent ear should be checked because undue folding and pressure can cause a problem. Even the dependent eye should be checked and should be securely taped because if the eye opens out, then there can be damage. The lateral decubitus position also is associated with pulmonary compromise in a patient who is mechanically ventilated. So, the lateral decubitus position is associated with pulmonary compromise. So, in a patient who is mechanically ventilated, which statement is true? Lateral weight of the mediastinum causes disproportionate cephalad pressure of abdominal contents on the dependent lung, favoring overventilation of the non-dependent lung. Pulmonary blood flow to the underventilated lung. Dependent lung increases owing to the effect of gravity. Ventilation perfusion matching worsens all of the above, which case is true in case of lateral decubitus position in a mechanically ventilated patient. The answer is all of the above. The lateral weight of the mediastinum. Lateral weight of the mediastinum. It causes pressure on the abdominal contents of the dependent lung. So it basically causes more pressure on the abdominal contents and favors overventilation of the non-dependent lung. So basically, uh, when the patient is in the lateral position, the dependent lung gets the lateral weight of the mediastinum on the non-dependent side causes pressure on the dependent lung. Because of this, there's overventilation of the non-dependent lung. Then pulmonary blood flow because of gravity will be more to the dependent lung, and hence as the non-dependent lung is ventilated more, dependent lung is perfused more, so ventilation perfusion mismatch will worsen. Patient may be flexed while in the lateral position to spread the ribs during thoracotomy, so improve exposure to the retroperitoneal flow renal surgery. The point of flexion and kidney rest, if raised, should be to answer this, it should lie under the iliac crest. So basically, it should lie under the iliac crest, okay, to prevent pressure on the thorax and the basically prevent pressure on the thorax and decrease the lung compliance. All are true about the axillary roll in the lateral decubitus position except placement in the axilla. So basically, it should be placed below the axilla. Okay, the whole point of the axillary roll is to bear the weight of the chest wall. It is basically a bag of intravenous fluid. Pulse in that arm should be monitored to check for compression of the pulse so that to avoid compartment syndrome. It is kept just below the axilla between the bed and the chest wall. All are true about the ventral decubitus position except it is primarily for surgical access to posterior fossa of the skull, the posterior spine, buttocks and perirectal area, lower extremities. As with the supine position, if the legs are inclined with the torso hemodynamic reserve is maintained, pulmonary function will be inferior to the supine or lateral decubitus position. The leg should be padded and flexed slightly at the hips and knees, and the head may be supported face down with its weight borne by the bony structures or turned to the side. So pulmonary function in this case is actually superior, the supine and lateral decubitus position. So it is primarily used for access to the posterior fossa of the skull, buttocks, perirectal area, posterior spine. And as with the supine position, if the legs are in plane with the torso, hemodynamic reserve is better maintained. And the legs should be padded and flexed slightly at the knees and hips. And the head may be supported face down with the weight borne by the bony structures or turned to the sides. The bony structure should bear the weight, and it should be seen that the eyes are free. There should be no pressure on the eyes, otherwise it can lead to post-operative visual loss. And the legs should be padded. All the bony prominences basically should be well padded. Extra padding under the elbow is needed to prevent compression of the So basically, the extra padding under the elbow is basically the most common injury is that of your arm. So it has to be the ulnar, because that is there at the elbow. So padding is needed to prevent compression of the ulnar leg. So all are true about the prone position except elastic stockings and active compression devices are needed for lower extremities to minimize pulling, especially with any flexion of. When general anesthesia is planned, the patient is intubated in prone position after adequate positioning and safety measures are in place. Endotracheal tube is well secured to prevent dislodgement and loosening due to saliva. With coordination of entire operating routine, patient is thrown onto the operating table, keeping neck in line with spine during the movement. So the answer is patient cannot be intubated prone. The patient has to be in the supine position intubated. So first the patient is intubated in the supine position on the trolley. All the monitors are disconnected. IV access is disconnected so that it does not come out. The IV access should be capped and the IV line disconnected. The patient is turned with the coordination of the entire operating team, a minimum of 5 members, and the patient is turned onto the operating table, and the neck has to be in line with the spine during movement to prevent any injury, right? Then elastic stockings are used to minimize pooling of blood, and the endotracheal tube is well secured to prevent. So basically, the prone position there can be a lot of drainage of saliva, right? So the endotracheal tube has to be well secured with tapes, because the tapes can be loosened because of the saliva. So by tying of the endotracheal tube even after putting the tape is also an option. All are true about the prone position except the abdominal wall is easily displaced. External pressure on the abdomen may elevate intra-abdominal pressure in the prone position. External pressure on the abdomen may push the diaphragm cephalad, increasing increasing functional residual capacity and pulmonary pressure. Abdominal pressure may also impede venous return through compression of the inferior vena cava. As such, careful attention must be paid to the ability of the abdomen to hang free and to move with respiration. So the answer is this. External pressure on the abdomen may push the diaphragm cephalad. This will decrease functional. This is very important. That's why in most questions I have put this. So it is very important, this change. Okay. It will decrease FRC and pulmonary compliance and increase airway pressure. So that is why it is very important the abdomen be free. The abdomen, so abdomen if displaced to any pressure can increase the intraabdominal pressure. The abdominal pressure may also impede the venous return because of compression of the inferior vena cava, so it will cause a decrease in BP. Also, the abdomen has to hang freely during respiration. That has, because of these, it must be paid attention to that the abdomen has to be hung freely. Now, pressure on the abdomen can also increase the pressure in the venous plexus in the back, and that can cause increased bleeding during surgery. So the main advantage of the sitting position over the prone position for neurosurgical cervical spine surgeries are all except excellent surgical exposure, decrease blood in the operative field, reduce perioperative blood loss, superior access to the airway, reduce facial swelling, but no benefits of the ventilation as compared to supine position, particularly in obese patients. So in these in these patients actually, there are benefits to ventilation. Benefits, basically there are benefits of the ventilation as compared to supine position, particularly in obese patients. So in supine position, what happens is the abdominal contents press on the diaphragm and decrease the lung compliance. Especially, and in obese patients, this can be a huge problem because already the lung compliance is low. So in the sitting position, there is no pressure on the diaphragm, hence no decrease in the lung compliance, and these patients benefit. So there is excellent surgical exposure because these are basically for the posterior fossa tumors. Decrease in the operative blood field and decrease in perioperative blood loss, obviously. Sorry. All are true about supine position except the head may be fixed in pins for neurosurgery or taped in place with adequate support for other surgeries. Arms must be supported to the point of slight elevation of the shoulders to avoid traction on the shoulder muscles and potential stretching of upper extremity neurovascular structures. And the knees are usually slightly flexed for balance and to reduce stretching of the sciatic nerve. And the feet are supported and padded, increase venous return. Basically, this answer, all are true. Actually, correct. Excessive cervical flexion has a numerous adverse consequences except it can impede arterial and venous blood flow causing hypoperfusion or venous congestion of the brain. It may impede normal respiratory excursion. Excessive flexion also can obstruct endotracheal tube and place significant pressure on the tongue leading to hypoglossia. The mandible and sternum should be in contact. It is recommended for normal size adult and patients should be positioned at a should not be positioned at extreme range of motion. So your answer for this is actually 4. This is not true. The mandible and sternum should not be in contact. There should be 2 centimeter distance between the mandible and the sternum, because this can cause, if the mandible and the sternum are touching, it can cause obstruction of the endotracheal tube, cause pressure on the trunk and macroglossia obstructing the airway. It can impede normal respiratory excursion, and of course any head change position can impede the arterial and venous blood flow causing hypoperfusion. Risk of air embolism is highest with which position? This is a very important question. Basically, your risk of air embolism is highest with your supine position. Positioning related recommendations to avoid post-operative visual loss are all except number 3. This has nothing related to. So guys, that was all about the quiz on positioning. Do use my code to avail your discount. Tomorrow class will be on obstructive sleep apnea. I will put up the time soon. Kindly avail your 10% discount. Have a good evening. See you guys tomorrow.